I'll show you a few things, right? So bougie, right? So another name for this is a tracheal tube introducer, right? When do we use it?
When you're intubating?
When you're intubating. So ideally, right, if you have this device, use it for the first intubation because you'll probably have much more successful intubation. So how this is usually performed is this. So I'm gonna start, not a picture, recording. And then this is, right, hyperangulated blade. So I'm gonna show you. So same thing, right? We find the uvula. The next thing I'm inching on the tongue until I see what? The epiglottis, and I slide into the vallecula. I'm gonna show you now if it goes in the stomach. So you see I went in the stomach, right? If, how do I know I'm in the correct location? I'll hold up. Hold up usually occurs right main stem bronchi. So look, I'm in the stomach. You see what's happening to the tube?
It can go and go and go
I'm gonna bury it, like it's already gone. Now I'm gonna go in the right location, so you want again 50% view, so it will allow entry. So now, right, let me come to the side. So now I went, you see, right, this is going in the trachea, and we want to see, right, we got what, hold up. So I feel that this does not allow me to advance it further, right? So what you're gonna do from this standpoint, right, you're gonna be my assistant, take out this stylet, and you're gonna lace the tube over. Notice I don't drop my blade, I keep it where? I keep it in the vallecula, right? And so she's coming, and then you're gonna grip the tip. Sometimes there will be hold up with this curvature, right? So you see the bevel? The bevel will hit like the vocal cords like this. So what you're gonna do, if you feel resistance, you can't advance, you're gonna pull back, you're gonna rotate, and then you're gonna advance. So you see the tube passes it, right? So then what we do is we basically remove, right, our bougie, right? We inflate, right? And then you have the BVM, right? And then you squeeze, right? You see the chest rise. Yeah, I didn't inflate it, but you should still have chest rise. Right? We still see chest rise, right? But we would inflate. The next thing I'll show you here, right? So this was a hyperangulated blade. So for the hyperangulated blade, as I said, right, you want a 50% view. Stylet, yeah, place it in there. The other blade that they have for the adult patient, this is regular geometry, right? Oh. This is regular geometry, right? So the benefit of this, if let's say I'm not familiar with the video, right? I can, when I go in, I can see the normal structure. So I'm intubating like I normally would. I see, right? I insert and I lift. So now I see the vocal cords, right? And this allows the person who is training to do regular direct laryngoscopy without using the screen. But let's say you're supervising me, right? Do you see the cords? And let's say I was advancing, I was here, and I'm saying I'm not looking at the screen, and I say, okay, I see it go in. Can you confirm?
Yeah.
It's in, right?
Yes.
So the benefit of this device is that the person who is intubating, they could use direct visual view to intubate, but the person who is supervising, they could direct and say what to do. So this is standard geometry, Mac blade. This is what? This is the hyperangulated blade, right? Stop the recording here. What else wanted to show you? So we did the bougie. We did hyperangulated with this. I don't think we have a peephole here. No, we don't. We don't have a peephole, but something I want to show you, right, which is important, so you guys see this. Right, so let's say we come to the patient, right, and we want to pre-oxygenate them, right? I showed you guys to use the what? The two-handed technique. So pass me the OPA, right, and a nasal cannula. So we'll put all of it. So OPA, right? So we measure central incisors to the angle of the mandible, cross-finger technique, and we insert, right? Yeah, the nasal trumpet, the nasal pharyngeal fluid. I don't know if this will allow the entry for me. Might be too big. Yeah, it's too big. All right, so it's too big, but we want to put a nasal airway, right? We measure from the nostril, the earlobe. Oh, this is good, yeah. And the way you insert this, slight traction. Don't push it back. You're gonna basically bevel to the septum and you're gonna go straight down. Right? Straight down. And I would put another one. If I had the right size, I would put 2 and the OPA. And then, right, I showed you, right, to lift this and then position and to ventilate. We said what? You wanna do, it's called the triple airway maneuver. You lift the mandible up, open the mouth and tilt the head back, and you do it with the mask, right? So if you squeeze for me, so open the cuffs, put the mask, right? And then squeeze. 2 1,000, 3 1,000, 4 1,000, 5 1,000, 2 1,000, 3 1,000, 4 1,000, 5 1,000. I'm doing this for 2 minutes to get nitrogen washout and to pre-oxygenate to 100%. So I'm looking at the monitor, right? Question for you is this. So this patient is right now positioned, right? Ear to the sternal notch, ear hole to the sternal notch. Do I need this position for BVM ventilation? Not necessarily, right? I could, if the patient was supine and I start to do my BVM ventilation, if my technique was good, I could still ventilate. Why do I need this position, ear to the sternal notch?
Intubation.
Intubation, right? So, but can you elaborate more specifically why?
It puts the anatomy in line and allows for easier facilitation of tube insertion.
So what he's saying is correct. So basically, to explain what he's saying is this: when the ear is to the sternal notch, it aligns the oral. So the oral axis, the pharyngeal axis, and the laryngeal axis. So it aligns all the 3 axes so that we can see the vocal cords. So oral, pharyngeal, and laryngeal, right? The 3 axes are aligned so that you could introduce the tube. If you keep the patients flat, right, without the positioning, you may be able to BVM them, but you will not get the optimal view in order to intubate. So everybody follow? So that's why we align ear hole to the sternal notch. In the field, right? So if they're on a stretcher, you could put it like this. If you don't have the stretcher, you could put padding under the head, right? Or like your O2 bag, right? Bunker gear or anything like that, fluids, right? To lift up the head up. I even saw like some places what they did was the one person would lift the head like this as the medic was intubating. So like if I was intubating, somebody's lifting the head up. It's not the best, it's not stationary. I also saw them lift the hands up, so the head is like dangling down. Also not the best, right? But as long as you align ear to the sternal notch, right, you'll get optimal view. So I think we saw that. Any questions you guys have? So with the bougie, with the different blades, no questions, everybody's good?